Well, so there's two ways to look at probability. You can look at it as a frequentist, or you can look at it, logically. Frequentist is tough because you don't really have multiple trials. Using like inferential statistics, you can try to make guesses like, well, what are the conditions that would allow for success? How many other drugs have been successful in this disease? Maybe that would be a good variable. How many drugs have been successful from this company? How many drugs have been successful just in general from phase 2? And I was just trying to get a percentage, that's all. And then if you buy calls or puts, you can actually get the implied percentage. Yeah, you like the exceptions to prove the rule. How many lotteries were won before I won? Right, so if you look at the 10 calls and you assume the stock goes to what, 15 or 20? If it's successful, well, you could say the market is telling you, let's say it goes to 15. If it's successful, the 10 calls are worth 5, and the last is 170 divided by 5. So the market's telling you 34% chance if it goes to 15. If it goes to 20, unfortunately, the market's telling you that's a 17% chance. So somewhere between 17 to 34% chance. So that's roughly a 25% chance. So the market's telling you it's not so great. Now, the market's not always right. I would say that the onus here is on the bull, not the bear. It doesn't take a genius to see all the flaws of this product. It's fairly obvious to me, to the market, to everybody. Now let's look at the puts, right? Let's say that the stock trades to $1. If it fails, well, then the 2 puts would be worth $1, and they're trading at 85 cents or 90 cents. So the 2 puts are implying a 90% chance of failure. People are willing to pay $1 for the 2 puts. Think about how crazy that is. It's the right to sell the stock at 2. It's trading at 5. Wouldn't that be worth 5 cents, 10 cents? No, it's worth 90 cents. The break even on the put is $1.10. It's to drop below $1.10 to just break even. So again, the onus is on the bulls. I mean, this is a really, really rough one. So I just feel bad for the longs who have a big position and don't realize that, like, this is what happened with INMB. This is what happened with all these other things. Like the longs will say stuff like, well, if it works half as good as it did in phase 2, the clinical trial science is difficult. Yeah, we've had the grid for a while, Brian. You divide and imply the chance so that it's branded you. If the stock goes to 50 cents and the 2 puts are worth $1.50, right? If it goes to 50 cents, then the price of the 2 puts are 90 cents. That's a 60% implied odds of failure. Now, market's basically saying 25.75 because the stock could also go to just $1. It doesn't have to go to 50 cents. Same thing on the long side. It might go to 15, it might go to 20. But either way, it's around a 75-25, according to the market, right? And I'm saying that 25 is vastly overestimating the likelihood of success. It's practically a 0. So, Peter, it's a good question. And basically, you're supposed to do it mechanically. So if I throw a dice, I can use the frequentist approach and just say, well, let me throw it 100 times, see what happens. And 16% roughly for each probability. That's 1/6 for each. Okay. But if you want to do it mechanically, it's a little bit different. You have to reason about it. And one of the ways I like to do this, and you guys know this, I've written many papers on this, and I've talked about this numerous times, but this is basically the necessary, oftentimes not sufficient kind of requirements. So the first is usually some kind of like designed drug, right? It has to be sort of logical on the idea side. Start with the idea in pharma, right? You say, I think this might work. And, typically that a good MOA is necessary, but it's not sufficient. Just having an idea doesn't guarantee you success. But I would say you sort of have to have a good idea. Now, how necessary is it? Necessary is a rough word, right? It means it has to be, but we know that, there are exceptions. It doesn't have to be, but I would say it's 90% necessary. You could be generous and say it's 50% necessary. Okay, now some of these probabilities are correlated, so you have to be very careful. So next is preclinical data. So, some kind of animal data or lab data should give you some confidence that the drug has efficacy. It's generally necessary. It's certainly not sufficient, unfortunately, or we'd have a lot of FDA-approved drugs. And what's the probability that you need this? Well, I don't know, we'll call it 50%. So now you have to sort of look at the actual thing we're looking at. And in this case, what's the probability that the phase 2 data or the phase 1-2 data are indicative of what's going to happen in phase 3? Now, the problem is this is a trick question because phase 1/2 data were not very good. So you almost don't want to replicate, this data. It's kind of problematic in a way. But let's say the idea is phase 1/2 becomes, more successful in phase 3, and that would be required in this case, and it would also be sufficient. But the probability this happens is the drug gets better over time, or that the phase 1/2 is kind of a or Boolean. It gets better in phase 3, or it's good enough. Just say good enough here for approval. And again, I think the odds of that are maybe 20%. Or contrary, you would say you need to be at 80%. So if you multiply these, you get a really low number. So there's a 10% chance you have a mechanism of action that makes sense. There's a 50% chance you can say that preclinical data is robust enough to get you a meaningful therapy. So obviously now you're at a 5% chance of success. And the chance that this phase 2 data is suggestive of success is really low. It's maybe a 50-50 being generous. So you have a 2.5% net chance of this drug working. You probably have to strip out some independent probabilities. So I don't know, maybe call it 10%. Now again, I'm a little more stringent here because there's other factors. For example, what are the odds that an intracellular protein is an important enough signaling molecule that by binding an inert membrane protein, you're going to get a successful outcome. Now again, that is an MOA, so it's sort of independent, but let's try another one. Let's say sarcoidosis. What is the chance that you're the first FDA approved drug for sarcoidosis? Now again, this is not a perfect thing, but assume that you can, you would have to sort of meet a 90% threshold there. And this, again, sort of conditional on this, so you can't really ding it twice. You can't penalize twice. The point is you would have to be the first new FDA-approved drug for sarcoidosis ever, in a disease that's been very, very tough to treat. You would also have to be one of the first drugs that doesn't have a protein-engineered drug that doesn't have a mechanism defined. That makes sense. You would also have to overcome the idea that the preclinical evidence is quite weak, and you'd also have to overcome the fact that clinical evidence is quite weak. Take into account the company's history, the probability of success here is 0. There's too many things that you would have to make true for it to be reality. And that's why the 25% implied probability is a gift, because the implied probability should be 0. It's very, very, very hard to reconcile all these problems. You don't have a management team that when this drug was created, that really had an experience. The drug was mostly created by a postdoc. The prior drug failed. So this isn't exactly a team that's been delivering, or quite frankly, if you look at their history, isn't really that great of a track record. Again, the main person developing this drug was just a postdoc, never worked in pharma. It shows. So it's just too hard, too unlikely. They should have just done a bigger phase 2, honestly. Save some money. Why not enroll 80 patients? I know COVID was tough, but again, Captain Hindsight here. The problem with the 2-puts is you really have to be right on the razor's edge of whether the stock goes to 50 cents or $1. It's just it's one thing. It's really hard to tell. I don't think MDs or PhDs have any edge in clinical development. It's a specific skill that you have to learn by doing. I trust somebody who's done it a bunch of times. And clinical development and drug development are two different things. And very few people do both. So that's why this skill is kind of hard to prognosticate. Wall Street's actually the best at it. It's actually a really good question, because it's the same hypothesis, actually. ADA signals? What's ADA signals? And drug antibody? Anti-drug antibody? Yeah, pretty immunogenic. So the 1940 was full-length HARS, whereas 𝗪𝗏 is more compact. So their whole thesis doesn't make sense. They're trying the same thesis twice. Jesus Christ, it's worse than I thought. It's worse than I thought. Yeah, so how in the world would the smaller domain be any more relevant than the big domain? This is so crazy. What a God, what a blessing. It's the full protein instead of just one domain, but I don't see how that could make a difference, possibly. Yeah, I don't see how they're any different. I mean, full protein versus partial protein, the only thing you could get is worse binding, right? There's no mini proteins that bind better than large proteins, right? So this is the craziest part of the story, and I'm just realizing it now. Domains are like parts of a protein. Like on my human body, this is my arm domain. Look at autism, SSRIs are proven to not work for autism. They're given 50% of autism kids. 50%. There's this like learned helplessness that comes with certain diseases where you go to the doctor, say, "Doc, what can you do for me?" And you're going to lose the patient if you don't do something. You can't just sit there and say, "Okay, sorry." Sarcoid is like, seems like it's autoimmune disease. Let me throw some steroids at it. Because, you throw steroids at patients who aren't breathing well. It seems like a good idea. But yeah, poor autism. It's a willful neglect. 𝗬𝗏 was used a lot before the trial proved it didn't work. They took it off the market. Yeah, you guys are there, right? Okay, good. So, is this the thesis? You have, I'll just do it in green, AARS, right? Intracellular, because that's what it's good for. Okay, it somehow gets out of the cell. Here it is, floating around. It's a signaling molecule or something like that. Uh-oh, here comes an antibody. The antibody says, "No, I don't think so, Mr. AARS. I got you." And now the patient gets myositis and interstitial lung disease. So far, so good? So if you have these antibodies, you get the sequelae. We're going to patients. So this is a guy, this is a rare disease guy who's got these antibodies, right? He's got these swimming around and he's sick. Okay. So now we're going to go to another guy does not have these antibodies, right? He's fine. He also has the AARS coming out of his cell. He doesn't have this problem, right? He is perfectly functional, whatever this guy had. There's no problem. Theoretically, there's no enzyme reaction. So there shouldn't be any myositis or ILD. This should be completely nullified by the fact that there's no antibody. So the hypothesis is give more R's, right? Basically just, okay, let me amplify this. Let me add more. More and more and more. This patient has myositis, right? And ILD. Well, actually, this guy just has ILD. He doesn't even have ILD. He has scleroderma. I'm sorry, he has sarcoidosis. This guy has this weird 𝗪1 phenotype, which is not sarcoidosis. So whatever's causing this guy's sarcoid, it's not an immune response to AARS. Because his AARS is fully functional. So giving more AARS, hoping to get a physiological impact on the disease, doesn't make sense. You're right, you will create AARS antibodies. So you have this weird mutant protein. But more importantly, what's the hypothesis? If you're deficient in vitamin C, you get scurvy, and you give vitamin C, the scurvy goes away. But if you're not sick, giving vitamin C doesn't do anything. It's like, or say vitamin D, it's like, well, let me just get more vitamin D, my bones will get stronger. No, it's kind of stupid therapeutic idea. And they tried this with myositis and it didn't work. So they did the same exact experiment with 1940 here, and none of this worked. It's the same exact experiment. So now they're just doing it with ILD. Well, the 𝗪1 is not related to their drug. The 𝗪1 is how they got the hypothesis for treating sarcoidosis and fascioscolenosis, how do you say this wrong? FSHD. Okay, I'm here to talk about aTyr, my short thesis. So this is a pretty confusing company, as you know, a lot of biotechs are confusing. And so we are here to talk about aTyr, aTyr Pharma, developing a drug called 𝗬𝗓𝗏 for sarcoidosis. So I am certain that this drug does not work. A lot of people always ask me, well, how can you be so sure? Well, there are ways to being sure. I'll try to convince you right now. Let me see if, in mathematics, the definition of a proof is a convincing argument that something is true, and convincing means you convince your peers. Basically, the company noticed, as did various people in the medical establishment, that AARS, which is acyl amino acid tRNA synthetase. Okay, this is almost exclusively intracellular protein. You've heard of it, basic biology, the whole tRNA kind of cascade. But evidently, I don't know if it's in some people or in everybody, tRNA, this AARS sneaks out of the body into the bloodstream, and for some patients, very rare, not many reported cases, maybe a couple hundred reported cases, okay? They form antibodies, called these Jo-1 antibodies, to AARS. And the phenotype, or sequelae, is this kind of weird myositis ILD syndrome, okay? And so the Jo-1 patient has these antibodies swimming around and has this rough syndrome. Fine. That is sort of reality. There's no debating this. This is all true. So now we go to the ILD patient. The ILD patient does not have Jo-1 antibodies, right? Something else is causing their sarcoidosis. And we don't know what that is exactly, but they have sarcoid, lung sarcoid, and they don't have any AARS antibodies. So the therapeutic theory here is, despite the fact that their AARS pathway is not blocked, it's not problematic in any way, that we're going to give a synthetic AARS, that I guess I should color this one in maybe purple, and the green one is native. We're just going to give a synthetic AARS with a FC region, and we're in essence supplementing the patient's kind of natural AARS, or whatever's happening when this protein leaks into the bloodstream. And the theory is that, well, if you don't have antibodies to AARS, you don't get this myositis or ILD. But I'm not sure I follow this hypothesis, where the more AARS I have, the less myositis or ILD I have, because I think we've proven that the patient's ILD is not caused by antibodies to AARS. It's caused by something else. So adding more enzyme, maybe the signal it's creating could lower the myositis or ILD, but it's sort of hard to imagine that the person's, whatever's causing the scleroderma, is being interfered with here. Boosting the AARS signal, if that signal even exists, is something that, you would think maybe could stop ILD or myositis, because when you have an antibody to that, you get myositis and ILD. So it's kind of this weird hypothesis where it's like, even though my pathway isn't impaired, I'm going to try to jack up the signal. Now, it's not the craziest hypothesis in the world, but there's a problem with it. The company already tried this. They tried it with their old drug, aTyr 1940, and they gave it to these patients, the myositis patients. And I'll just make that drug in orange, but it was basically the same thing. It was a larger domain. It was almost the full protein instead of just the, part of the, one domain. But they did this in myositis patients, it didn't work. Why would it work in ILD now? Doesn't really add up. And the preclinical data is bad, and the clinical data was bad. So it feels like there's no chance this could work based on this, pretty implausible mechanism. I mean, ILD Sarcoid, there's no one cause of sarcoid. There's a lot of little causes, it seems. It's obviously a very quixotic disease. It kind of comes and goes. Many patients don't require treatment at all. So boosting this signal, if the signal indeed is sort of this gateless, anti-inflammatory, anti-immune signal, which at least when you see the antibodies, you see that it causes this problem, but it doesn't mean that because you add more that there's not a ceiling. Again, I don't even know why the AARS antibody syndrome happens. It's very rare. But adding more doesn't seem like it would actually create efficacy, because you're assuming that whatever AARS is doing, it's going to override all the other disease signals. And then two, that there's even the patient has AARS. So it's not like they're missing it. They have plenty of it. So we're going to add even more. There's no homeostasis and it's gateless. There's no limit to how much benefit you can get from it. So those are really unlikely, especially since we've seen in 𝗪𝗀𝗆𝗄𝗆 muscular dystrophy, FSHD, that their old drug didn't work. So that's my kind of general thesis about the therapeutic hypothesis. Obviously, the clinical data, preclinical data, we've covered in other places, but that's kind of where the idea kind of comes out. So I hope that cleared some things up. And is that a convincing argument? I mean, the Joe antibodies sort of are convincing that, I guess the addendum here would have been undefeated, uncontested, best group ever for sarcoid. No, I mean, so think about it. If I have an antibody to AARS, I get sarcoid. Okay, let's keep it simple. I have an antibody to AARS, I get sarcoid. But I have sarcoid and I don't have antibodies to AARS. So do I give more AARS? You have to have this theory that AARS is stopping the sarcoid in the first place, which may not be true. And then, I didn't mention the most important part at the end, which is what happens when you make anti-drug antibodies. Now, you can have antibodies without having a untoward reaction, right? So, are they really testing for antibodies every week? All drugs cause some amount of them. This is the question of, is the patient blowing up or not? It could be less immunogenic, it could be more immunogenic. It's definitely a native protein. It's a new protein nobody's ever seen before. It's so weird, man. I think this GPU bubble may. But does the Joe 1 theory make sense? This is their theory for why bother doing this at all, right? Their theory is if you stop AARS, you get this weird syndrome. But that could be for some really bizarre reason that has nothing to do with AARS having a beneficial effect. It could be intracellular for all we know. There's only 100 people who have ever had AARS-caused sarcoid, and this would not help people with AARS-caused sarcoid. It would only help people, rituximab would help those people. Record account levels. Thank you guys, you help me by giving me good stock ideas all the time. I appreciate it. Rituximab didn't work in sarcoid? Well, I'm talking about the Joe 1 antibody patient. Yeah, it's not a B-cell disease, right? Joe 1 is a B-cell disease. You love to see it. You just love it. I'm short in Huma too. Yeah, D-Wave decline's just getting started. No doubt about that. I love that the SPIs are down 30 basis points. That's all it takes. We're getting some big relief. Stocks are down 5 to 6, 7%. All right, the great bear market of 2025 has begun. We'll be right back. Don't go anywhere. Go to 𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏. Sign up today and support the stream. If you like my stuff, that's how you get back.